start seeing attendees coming in. And we are recording.
And if for whatever reason I get bumped off again, I'll just join back in.
Okay.
Great.
We see participants coming in on the line. I assume they can hear us now. And if you'll just give us a couple more minutes, we'll get started. It's just 2 after the hour. Why don't we wait one more minute and let people get a chance to get in? I'm still getting people who are signing in.
Yep. Welcome everybody that's signing in. Just give us one more minute and we will get started.
I think we should probably get going.
All right. Thanks everybody for joining. My name is Rhiannon Klein. We are Community Voices for 340B. And I'd like to introduce our Regional Director in Texas, John Reed, who is going to say a few words to kick us off. John, take it away. John? John, it's all you. All right. John Reed? All right, well, I'm going to go ahead and kick it off. Thank you for joining us. We are CV340B, and we are a grassroots organization who is doing advocacy around the 340B program in the state of Texas. We're excited to bring this program to you today. We are looking forward to highlighting 3 wonderful healthcare providers in your communities to talk about how the 340B program works for the people that they serve. First off, we'd like to highlight Michelle Durham from Beat AIDS, who is our primary sponsor, and thank them for coming on board. Go ahead, Michelle.
Hello, and welcome to the August 2020 Virtual Texas Opinion Leader Forum on 340B. Community Voices for 340B and Beat AIDS have sponsored this forum. I'm Michelle Mayfield Durham, and I'm the Executive Director of Beat AIDS. It is an honor and a privilege to participate in this forum and to empower Texans to continue to move forward, making positive change with this much needed program, 340B. God is the head of my household, and he gives me all my strength. And so I'd like to honor God as well. I think we would be remiss if we did not pause for a moment to reflect on the many lives lost at the hands of social and racist injustice, and to honor the Black Lives Matter movement. Also, to reflect on individuals who are ill or who have passed away due to COVID-19. And lastly, to honor our brothers and sisters who have gone due to HIV/AIDS. Let's take a moment, please, of silence at this time. Thank you to John Reed and to Rihanna Marshall Klein for including us, and to everyone who's agreed to participate in this forum this afternoon. Thank you all for being here, our participants, and I hope it is informative and that you have a good time this afternoon. And now I give you Ms. Peggy Tai.
Hi, everyone. Thank you very much for joining us today. We're really excited to talk to you about a program that many of you may have never even heard of before, the 340B Drug Discount Program. I am a principal at Powers Law Firm, and I work with 340B, Community Voices for 340B, and have since the inception of the program. The main genesis of this program was to ensure that people who are benefiting from the 340B program had their voices heard, hence the term Community Voices. So again, a little known federal program. We're going to give you all kinds of information about what it is and how it works. But ultimately, we want you to know about something that is probably helping you in your community, and in turn, hoping that you will help us protect this program. Rhiannon, why don't you introduce yourself, and maybe we can get John back on the phone. If not, I'm going to introduce you, John.
I'm Rhiannon Marshall Klein. I have also been with CV340B from its inception. I am our National Field Director Manager, so I oversee all grassroots advocacy for CV340B. I'm proud to be a part of this organization as we do our grassroots advocacy around the 340B program, which continues to be a vital assistance to our healthcare safety net. Looking forward to speaking with you a little bit later about advocacy and how you can advocate in your community. We'll kick it over to John Reed, see if we can get him this time. John, will you introduce yourself?
John, just move your mouth and I'll put words in it. How's that?
It's true.
All right, so let me tell you about John Reed. John Reed came to us through Rhiannon, actually, and from other folks John had worked with in the past, mainly in the HIV/AIDS space. And he came to us and said, I want to help you tell the world about how important the 340B program is, because I know how important it is for patients with HIV/AIDS. John is not only a pastor, he's also a passionate advocate who is from Texas. So recognizing that the voice of Texas patients and citizens was important to us as an organization, we tapped John Reed early on, and many of you on the phone probably know him because he was hounding you to be on this phone call today. And we're hoping that you will do him a solid, if you will, and tell your friends about this webinar, perhaps even send the video to him of Peggy Tai posing as John Reed. John, I'm so sorry they can't hear your voice because it's such a good one. But anyway, we'll go through the presentation. Maybe we can get your video on, or I'm sorry, your audio on later. So now what we'd like to do is one of our allies, AHF, has come up with what we think is really an excellent video about the 340B program. And nothing, I think, describes the federal 340B drug discount program better than this video. So we're keying this up. It's got cute little graphics and everything, but it's very simply explained what and how the 340B program is and how it works for communities like yours all across the country and in Texas. So Rhiannon, go when you're ready.
What is 340B? To find out, let's go back to the early 1990s. Money was tight, as it always is, and it was a difficult time for America's safety net providers, those providers treating large numbers of poor and uninsured patients. So as part of the Bipartisan Veterans Healthcare Act of 1992, Congress created the 340B Drug Pricing Program. The 340B program allows qualifying safety net providers and certain qualifying hospitals to buy prescription drugs at discounted prices from drug makers. As Congress stated, the goal of the program was to enable these entities to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. And since 1992, that's just what 340B has done. Let's explore how 340B actually works. Here is a small clinic in Ohio that participates in the 340B program, and two of their patients, Bob and Tina. Now let's say a 1-month supply of a diabetes drug costs the clinic $1,000 from a drug maker. Tina has private insurance, which pays the clinic $1,100 for her medication. Now, Clinic A has $100 in income. But with 340B, the clinic can buy that same drug from the same drug maker at a special lower price of $600. With 340B, the clinic still gets paid the $1,100 by Tina's insurance, but the sale now generates $500 in income, which the clinic must use towards its expenses. Now, along comes Bob, another patient at the clinic. Bob doesn't have insurance, but he needs medication too. Fortunately for Bob, the clinic now has that $500 in 340B savings to help pay for his treatment, and that $500 hasn't cost taxpayers anything. Without 340B savings, many clinics and organizations would have to find new money to stay open, most likely from taxpayer dollars. Either that or the clinic might be forced to send away patients like Bob, and those patients go untreated. Or worst of all, the clinic could close down altogether. But thankfully, clinics and their patients thrive with 340B because it allows clinics to offer better means of treating and keeping patients in care. The 340B program is already well regulated by the Federal Health Resources and Services Administration, which established rules that manufacturers and providers must follow to participate in 340B. Congress also keeps a very close eye, and 340B safety net providers and hospitals are subject to oversight, monitoring, and regular audits. Smaller safety net providers like Ryan White clinics who treat patients living with HIV/AIDS are concerned because the mechanics of 340B are often questioned or reevaluated by lawmakers and challenged by drug makers that would rather sell their products at a higher price. The truth is, this small program that does a world of good only accounts for 1.3% of all drug purchases in the U.S. We want to protect the vital assistance 340B gives to Ryan White clinics and all safety net providers. 340B has been working as intended for safety net providers and their patients for over 25 years, and that's why we'd like Congress and elected officials to simply let it be. To get involved and find out how to protect 340B, visit let340b.org.
Great. Well, I hope that maybe explains the 340B program in a simple way for you all to understand what it is we're hoping to talk about today. So starting off, thank you, Michelle, by the way, for your wonderful inspirational words. I want to talk about the organization. So CV340B, its mission and goals. I started earlier by talking about, why does this organization exist? And this organization exists in large part because there are groups who are trying to take away those drug discounts, those savings, as we call them, from the 340B program. It's really kind of spiraled out of control in such a place, and I'll get into this much deeper later, that manufacturers, those drug manufacturers, who are the ones giving the discounts, really don't want to give those steep discounts anymore. There are states who are trying to take the funding away. There's also these, what they call pharmaceutical benefit managers, who are kind of middlemen in the drug dispensing process, who also want to take away the benefit of 340B. So many groups are coming after us. We are the safety net. So we're Ryan White clinics and hospitals, all kinds of hospitals, rural and cancer and children's hospitals. We'll go into this in more detail. So why do we think we need the grassroots, you all? Why do we think we need average people to help us protect this program? Is because we're threatened. Is that there are folks out there who are trying to take away the savings that we enjoy and we were given by federal law, and we have a big problem with that. So we need help. We're fighting against pretty large entities in the drug manufacturers in particular, and we need that kind of help. So our board of, our mission and goals, let's start there first, is that we are a not-for-profit organization and we're dedicated to educating the public about the importance of the program. Our goals are to seek awareness, raising awareness of the important role that 340B plays in improving healthcare access and quality of care. And you're going to hear more from our panelists about exactly how the 340B program works in Texas, in your communities, to improve healthcare access and the quality of care. So here is the quick way of how I describe what we do. We educate, we document, and we communicate and elevate the success of the 340B program. You can learn more about CV340B at our website, which is not coincidentally, cv340b.org. Here are our board members. They are folks who are businesses that are in the 340B space and work very closely with those hospitals and clinics I've described before. And you've heard about Michelle, of our two Michelles today. Thank you again, Michelle Durham from Beat AIDS. She is going to speak again, and you'll hear a little bit more about them, but I wanted to take a moment to thank you in particular for being our sponsor and host today. So the 340B drug discount program, and that video was really great, so I'm going to go through this pretty quickly. It was established in 1992, and it was bipartisan legislation. So basically what was happening back in 1992 is that drug prices were going through the roof. Sound familiar? And members of Congress said, hey, what are we going to do about drug prices going through the roof? And they thought it would be a great idea to require the drug manufacturers to give a specific discount on the drugs to the neediest and most underserved populations. The way they determined who were the most needy and underserved populations is by defining which safety net organization which would be eligible to participate in the 340B program. So they chose over time hospitals, Ryan White clinics, hemophilia treatment centers, cancer centers. Those hospitals I mentioned earlier have to serve more Medicaid, Medicare patients. So really the neediest of the needy is how the genesis of the 340B program and the years of 340B have evolved into is a select group of organizations that are known for taking care of their public health needs and their community's needs. As not-for-profit organizations, all those covered entities in the 340B program, as we call them, have to reinvest anything they get from this program, or frankly from anything else they do, into the patients and communities that they serve. That's the beauty of this program. This is not for-profit anybody's. Nobody's making out like a bandit because we're churning our money that we get from the insurance payments that were described in that video back into the communities. I think it's incredibly important. Most of us, when we think about grantees or funding sources, think about, well, the government gave us that money. It's either federal money or it's state money. In this case, this is not funded by the governments, any government. It is an off-the-top, upfront discount on drugs to a specific group of needy or organizations that serve the needy. So it's really different from anything else you probably heard before because it's unique and it's special, and we think it works really well. Moving on. So I think we didn't warn you about us doing this, but we're going to do it anyway. So to make sure, to hope that you're participating with us, we've got peppered throughout our presentation a couple quiz questions to see if you're paying attention. So you won't be judged on this. We won't kick you off the phone, but this would help you, we hope, help you to follow along. So Rhiannon, you want to take care of walking them through this quiz question?
Okay, true or false? As a condition of selling pharmaceuticals in Medicaid, drug companies are required to offer discounts to safety net providers through the 340B program. You can drop your answer in the chat box, and we will see it there. Don't be shy.
I just said this. Come on, I know you can get it.
True, that's right.
It was in the video too.
Gold star to Andy and gold star to Rhonda. Very good jobs. That is true.
Just to explain this, so here's the trade-off. It isn't that the government just came in and said, hey, drug companies are going to have to give discounts. They said, you're going to make a lot of money in the Medicaid program. You're going to sell drugs through the Medicaid program. So we think we're going to the government, we're going to require drug companies to do something good for the safety net. That's the trade-off. Next, so I had mentioned covered entities in the 340B program, and I just rattled off a few. This is the full list of look at these groups. And if you think about them, if you can find any more deserving group of organizations who really care for these communities, I challenge you to find them. Sexually transmitted disease clinics, Ryan White clinics, children's hospitals, tribal centers. This is who Congress picked over the years to be eligible and entitled to the 340B upfront discounts. So back to the quiz, Rhiannon.
All right. Which group is not a 340B covered entity? Ryan White clinics, Black lung clinics, hospitals that have more Medicaid, Medicare patients, physician oncology practices, Native Hawaiian health centers, or children hospitals?
We know
Drop
we
it.
we
chat.
gave you 20 seconds to memorize that last slide, but we're guessing you might be able to get this one.
I think we've got some pretty savvy folks on here. All right, seeing a couple of things.
Which is not a covered entity.
And it is physician oncology practices for everybody in the chat who said, yep,
So there's
physician
nothing,
oncology.
there's nothing wrong with physician oncology practices, but the point is that for the other covered entities in the 340B program, the requirement is that you are a not-for-profit entity. Most, if not all, physician oncology practices that we know of are not-for-profit entities. So if we all decided as a country and Congress decided as a country that we should give them eligibility in the 340B program, let's do it. But as of right now, that is not an eligible category of providers under 340B. So this is where it gets fun. So I mentioned earlier about pharma and bio. If you've never heard those terms, those are kind of terms of art or organizations that function in the national federal arena. And they are comprised of drug and biotech companies that have recently, in the last 5 or 6 years, worked very hard to try to limit the 340B drug discount program. Now, I told you earlier that pharma and bio don't make as much money as they would have made, but for the 340B program. So if there was no 340B program, they would make more money. So it shouldn't come as a surprise that they are challenging the 340B program and trying to change the program. In Congress in 2017 and 2018, which feels like 100 years ago, they tried very hard to make dramatic changes to the 340B program, and Congress didn't make those changes. So there weren't the legislative actions that made changes to the 340B arguments, or 340B program, even though pharma and bio threw everything they had at trying to make congressional change. And that was in no small part because of groups like Ryan White clinics and children's hospitals and others who jumped up and said, wait a minute, this is not okay. We're not going to put up with this. And so those legislative changes proposed during those years did not happen. More recently, some of the drug manufacturers, back one slide if you don't mind, Rhiannon, drug manufacturers are trying something else. And what they're doing is they're attempting to regulate the 340B program themselves. So just in the last 2.5 months, while we're in the midst of COVID, several manufacturers, at least five, have put out letters to these covered entities, these safety net providers, requiring data collection. Give us information about the 340B program, give us information about your patients, give us patient records, and you can trust us, say the drug manufacturers, that we will keep all that information confidential. Well, the safety net providers are saying, hold on, what is it that you're asking us to do, and why are you trying to have oversight of the program because you are critical of a discount that you think you're providing in 2 different places? Why are you coming after the 340B safety net providers? That doesn't seem fair. So again, this has just happened in the last 2.5 months, and those letters coming from drug companies to the safety net providers, those hospitals and clinics, are saying, give us information. Hospitals and clinics are so concerned about this that their national organizations have written letters. Some are planning lawsuits. Some are written letters to the Secretary of HHS, to HRSA, which is the organization that regulates the 340B program. Some of them have talked to drug manufacturers directly to say, what are you doing? We're worried about this. This isn't going to work. It's a big storm right now. And we think from the covered entity perspective that really what the drug manufacturers are doing is, because they didn't get what they wanted in Congress a couple of years ago, they're trying a different angle. And the different angle is that if the agency that's supposed to regulate the program is not going to step up and stop them from what I consider drug manufacturers self-regulating the program, then they're just going to do their own thing. And really making up the rules as they go along does not seem fair to the hospitals and clinics who we work with. So going forward, there's more. But wait, there's more. Not only are the pharmaceutical companies have been coming after us for years, in the last 3 or 4 years, I mentioned this earlier, the insurers and pharmaceutical benefit managers are discriminating directly against these 340B safety net providers in contracts. So when the hospital or the clinic is buying the drug, they're not just buying it from the manufacturer. They're working with these pharmaceutical benefit managers, and insurance is related to this, like the video told you. So there's other players, or as we call them, stakeholders in the mix. 2 of those stakeholders, insurers and these PBMs, have gone to the hospitals and the clinics and said, okay, we see you're participating in the 340B program, so we're going to give you less money for your contract because you're getting a discount from the drug manufacturers. Well, I can tell you one thing for certain. When Congress wrote and created the 340B program, they never meant for the benefit to go to a for-profit insurer or to a for-profit pharmaceutical benefit manager. So what's happening, we think, is violative of federal law, and it should be opposed in every state. The good news is there are states, at least 5 or 6 of them, that have passed prohibitions on this kind of behavior by the insurers and the PBMs. Most recently, thank you, anybody knows anybody in Georgia, there's a new law in Georgia that we're very excited about that puts in this prohibition against that kind of behavior. Some states are also, states, I should say, state governments are trying to take the benefit of the discounts for themselves too. So the drug companies don't want to pay the benefits or give the savings. The insurers and the PBMs are trying to take a cut of the savings for themselves. And now the states are jumping in and saying, well, why don't you split the savings with us? So this is a problem. It's called the carve out. It's too complicated to get into on this short of a webinar, but covered entities are fighting in New York and California to try to prevent the state governments from looking to the 340B program as something that they can just take money from. What I've described it as before is it's like robbing Peter to pay Paul, if you've ever heard that phrase. So if a state takes away the 340B savings from, let's say, a Ryan White clinic, that Ryan White clinic is crippled in its ability to care for those people who need those drugs and those services. So the state's not doing themselves any favors by taking that money away, because they're then going to be the ones who are going to have to pay to care for those same people. So we're on a mission to educate in New York and California and in other places, states, that this is a penny wise and pound foolish approach to try to take away the 340B savings.
Okay, we have a question in the Q&A, which I think is apt. What do pharmaceutical manufacturers plan to do with the information that they're asking for?
Well, that is the question, I think. It's a really, really
me too.
important question. Is for years, the manufacturers on Capitol Hill were saying, give us information about how you're using your savings from the 340B program. Give us this, we need all this information. And we knew that those efforts were attempts to scale back the program. Pharma's not in this fight in order to give away more savings, right? So whatever they're doing is probably to do less savings. I think that's not a leap for us to assume that. If they have information that, let's say, manufacturer does the best they can to keep that information from having any problems with privacy. So you hospital, give all your information to a manufacturer. Manufacturer does everything right, but that information gets hacked. And all of a sudden there's your private, personal medical information out there by whoever has hacked it. The huge legal problem here is that if I'm the hospital and I turn over your personal medical information to a manufacturer and it gets loose, it's still my fault, right? So it's an uncomfortable place for clinics and hospitals to be, to just trust that the manufacturers are going to, number one, protect that information jealously, to keep that privacy together. And if something does go wrong, they should be the ones responsible, not the clinics. So what else they could do with the information is compile it in such a way, and we've seen them do this before, as to suggest that the 340B program needs to be changed or reformed, as they call it, to, again, shrink the program. That's what we're greatly concerned about. And I know Michelle and DJ can probably answer some of those questions too, maybe once we get into the panel. But I'm talking too much, and I want to get back to, if we're moving on, I think, next slide.
Yeah.
To Michelle. So Michelle, thank you again for your intro, and you're up.
Hi again. I feel really privileged to be on this panel with DJ and Michelle Atkins. Hi to both of you guys. I guess I'll jump out here and go first and tell our community and our participants a little bit about Beat AIDS. So we were able to go from an ASO to our first community clinic at the end of 2017, December 2017. So that's from an AIDS service organization to Your Choice Clinic. And then in May of 2020, in the middle of this COVID breakout, we opened our San Antonio Care Center. I'll tell you a little bit more about both. Next slide. So one of the things, making a transformational difference as we continue to serve our community and trying to ensure that all of our clients get maximum use of any benefits that are afforded to them, we have got to continue to have lots of connections and partnerships. And so this picture on this slide is us partnering with our Barrett County highest elected official, Judge Wolf, and the Commissioner's Court, saying this is a program that's important, as is that's our Walk Run program. And these are the partnerships that allow us to have a 340B clinic to begin with. So I wanted to emphasize partnerships. My part of the speech is not so much to make sure that everyone becomes advocates, as much as I was hoping that people who are interested in starting a 340B program will get some information from how we did it and be able to replicate and duplicate at their organizations. So looking into developing pharmacy partnerships, talk to the local pharmacists, find out if they've got specialty pharmacies. And in our case, it's Ryan White Core Services and 318 Contracting, which I'll tell you a little bit more about. So we knew who those pharmacists were and started having conversations with different pharmacists in our community about the fact that we wanted to open a clinic and we wanted our clinic to be 340B qualified. So, yeah, like I said, we've been offering services since 1987. We started off as grassroots with education and information, Believe it or not, that is me getting my blood pressure taken at one of our health fairs. And we decided that our clinic had 3 primary objectives. Number 1, to reduce the incidence of transmission of HIV, which means we were looking for U equals U. Number 2, to eliminate the gaps in HIV/AIDS treatment services. Much like that video showed, we wanted some extra money to be able to help people who have no insurance or money to pay for their health care, and to improve the health outcomes of minority populations. Our mission from the very beginning has been minority oriented. Beat AIDS is an acronym that stands for Black Effort Against the Threat of AIDS. Our secondary objectives were to provide STD treatment, including PrEP, pre-exposure prophylaxis for persons who are HIV negative, and hepatitis C treatment. So as we were making our plans to go from being an AIDS service organization primarily with outpatient substance abuse, case management, transportation, and some of the other services testing, we figured out what our responsibility would be if we opened a clinic. And so we would do the outreach. We've been doing outreach since 1987. We would sign up on what's called the OPACE HRSA website. But don't worry, don't fear, because the pharmacies that you partner with will walk you through how to sign up on OPACE. And if not, then I'll walk you through. I'm happy to help any organization who wants to do this. Our job was to make sure we have referrals for our patients if they've got another specialty need. The medical coding, we offer transportation and have patient navigators as well as linkage specialists on staff. And then, of course, offering resources in the community through our case management department. Now, we asked our partner pharmacies, and we went over this PowerPoint with them, to help us find a facility where we could offer a clinic, because Beat AIDS did not have a clinic before 2017, the end of 17. I'm gonna call it beginning of 2018. We asked them to help us find a doctor that was interested in helping our patients with STIs and HIV treatment. They were the ones who helped find a place called Hospital Prescription Management, which is our 340B third-party billing sort of specialty company between us and our initial pharmacy that we partnered with. And they offered to help us with marketing, because marketing can get expensive, billboards and commercials, etc. We decided early on, but both parties would be responsible for the training of staff, making sure that all the staff understood 340B, the importance of what we were doing, and how we were going to make sure that our clients not only came to a clinic, but they were able to get their medications right away through our partner pharmacies. We talked about the prescription process. What documentation does our pharmacy need to ensure that even if a patient had no insurance, that they could get their medication? And lastly, of course, the management of the 340B program. What data do they need? What data do we need in order to make sure that Beat from the cost savings principles that you heard Peggy talk about earlier. So our example, as we were showing this to our board of directors, we showed it to our consumer advisory board, we showed it to our doctor that we were recruiting, and to our pharmacy partners. We said, okay, if our grants and our agency resources are bringing in a revenue of $100, the 340B would bring in a revenue of approximately $200, and then our third-party billing to the insurance companies could bring in another $100, then that would be an income of $400. The expenses for the doctor, the nurse practitioner, the labs, the facility, the medication, and other support could be up to $700. So what we did was, in our case, we asked our partner pharmacy that we got with to also invest in our startup, because the startup cost for starting a 340B clinic, clinical services is, doesn't make enough money, all right? So the pharmacy, we got lucky, was willing to put in and help us out. And that's how we ended up getting growth, efficiency, and profit. So find a really good partner like we did in Empire Pharmacy. So the road to our grand opening, we created a timeline. October 2017, we started enrolling patients, seeing if there were people that we were finding newly diagnosed or who were coming back to care, who who would be interested in coming to a more grassroots, community-oriented clinic. And we saw patients who said, yes, absolutely, please. We started making sure that we knew how to do the referral process for our pharmacy partners that we put into the OPACE system. We started credentialing our doctor, Dr. Fernando Garcia, who's with us still today. Signed our agreement with our doctor and our pharmacy partners. In November, we started looking at other pending credentials, Aetna, Blue Cross Blue Shield, all the different insurance companies. Identify what equipment and furniture we would need in our clinic because we found the facility and we needed to stock it. And then we started talking about the processes for billings and operating our practice management office. And that meant talking to nurse practitioners and other people who have already run clinics so that we could just kind of get the data and information we needed. Our plan was to have a soft opening in December, and we did. This is our main office, our headquarters. It's at 208 West Euclid Avenue, San Antonio, Texas, 78212. It is a historical building and house, and most of our patients say that they are so happy to have the organization just kind of be in the neighborhood and not be standing out and that kind of stuff for confidentiality purposes. Just wanted y'all to see it. And location's critical. It's right in the heart of where most of our patients live. We had the honor of getting a grant through AIDS United, and we were able to go down to Louisiana, New Orleans, and visit Crescent Care, as well as talk to the Busy Bee folks in Houston. They told us literally how they went from being an ASO to having a clinic in 340B clinic. That also helped us come back to San Antonio and replicate the process. They even shared policies and procedures, et cetera, as we would do as well. That was their patient waiting room. These are initial partners. AIDS Healthcare Foundation gave us some funding to help us get our clinic going. Walgreens Pharmacy has given us swag and other items to help give incentives to our clients. Life Care Pharmacy is the pharmacy that we partnered with. They did that initial partnering with the funds to ensure that our clinic could get off the ground, and Avita Pharmacy. So we were lucky in that we did have a partner federal organization who allowed us to buy our electronic health record, and that is called NextGen Healthcare. So we've got our NextGen health record, and we are still, believe it or not, 2 years into having our clinics learning how to manage all of NextGen. It's that complex. So we're continuing to learn how to use our electronic health record. And I hope if we do one of these Texas forums next year, we'll be able to tell you more about how to take that to the next level and maximize the use of an electronic health record. Again, we credentialed our doctor. We brought him on board. He was like, I'm all for it. Whatever you guys need, let me be there. And he loves helping patients, especially patients who may fall through the cracks and might not get access to medical care otherwise. We renovated the facility, made it beautiful. I wish I'd have put some pictures on this slide, but they told me I only have 10 to 15 minutes. So if we have a longer time, I'll show you guys more about both our clinics next time. And then, of course, we had to buy the equipment for the doctors and recruit the clients. Recruiting the clients is key. So thank you so much for letting us share with you about our 340B. I'll answer more questions as Peggy starts to ask us questions later.
I guess I take it away now.
Oops.
Peggy, I think that Peggy is on mute.
I was waiting on somebody to do something. Okay. Michelle.
Actually, I just gave a great speech that nobody heard. Sorry. So I was thanking you, Michelle, for doing such a great job. And I did have a question for you. Can you talk a little bit, you mentioned about marketing, and marketing costs are expensive. Why is marketing important for your patient population? Can you talk a little bit about education and the continuum of care and getting and retaining folks into care?
So I meant to tell you guys a little bit about some of our pre-COVID and post-COVID benefits. And marketing is one of the things that we do mostly through social media. And post-COVID, with us all being forced into these virtual platforms, we've been able to make more robust. But before COVID, of course, our clients seem to respond the most. We did some surveying to billboards in neighborhoods, believe it or not, and actual physical facilities where they are part of the walking traffic. So the marketing is very important, because if we don't have any patients, there will be no medications, and there won't be any savings, and there won't be any money to help another patient out.
Right.
So
That's helpful. And keeping folks in care is a challenge, right, for this population?
absolutely. One of the things that I did want to mention is post-COVID, we were able to start our telehealth program. And part of the reason we were able to get the computers and get everything that we needed to start telehealth right away is because we had the 340B funds. So 340B has definitely been beneficial to Beat AIDS, both pre-COVID as well as post-COVID.
Thank you. Okay, now we've got a Michelle with 2 L's in her name. So Michelle Atkins, I'm going to turn it over to you.
Well, thank you so much for the privilege of speaking today. I see John is back on, and for those of you that are audience members out there, we can't see and tell, but we had a great practice run at 1:30. Everything was working fine until we go live. And John, can you hear me now?
Yes, I can hear you. I just got back out and I don't know what went wrong.
There he is.
So
Yeah.
I don't know if you want to take a moment to say anything before I start right now. It doesn't matter to me, however we want to do it.
Thank you, Michelle. Yeah, please, John, do.
Thank you, Michelle. Y'all got started without me. I don't know what went wrong at the beginning. Like she said, we had a practice run and everything was fine, and all of a sudden I just went blank and couldn't get back on. So I want to thank everyone who's on. And first of all, I want to, say that I'm gonna be praying for everybody that's in the eye of this here storm. Amen. And I know that's causing a lot of folks not to be on here today because it is in the path of Texas. So I just want to thank everyone who's on here. Thank you, Michelle, and thank you to other Michelle and DJ. I'm just glad that we was able to bring this here to Texas, and maybe next year to be better.
Next year, I want to do this next month. All right, go ahead, Michelle.
So again, thank you so much. Let's go ahead and advance the slides. I'm coming at you or coming at this presentation from a slightly different angle. Again, as my title indicates, I have some authority over compliance. And we at JPS Health Network, which is out of Fort Worth, Texas, have a full-time auditor who helps us ensure that we have ongoing auditing and monitoring to preserve the integrity of the 340B program. So my role is to make sure that those audits get done, and once a year we have an external assessment to make sure that we are above board, crossing every T, dotting every I to make sure we are 100% compliant with this program. So what I want to do next is brag a little bit about JPS Health Network, if you don't mind. And then I'll talk about, what some of the services that 340B allows us to provide. And then what we've had before COVID, and then, some of the services during and after, or not after yet, I guess. So again, you can see here that we are the only level 1 trauma in the county. Again, Fort Worth, Tarrant County. We have the only psychiatric emergency department, which is extremely busy in the county. Tax supported, 578 beds. You can see all of these things here. The DSH, for those of you who do not know what that is considered disproportionate share eligible. The 340B program actually requires, I believe it's 11.75% disproportionate share. In JPS, actually that number has changed. It's actually 49.75. So we as you can imagine, way exceed that number. We do have 13 pharmacies altogether, roughly 1.2 million scripts a year, 5.5 million dispenses. We have about 7,200 employees or team members. And even though we are a safety net hospital, go dance to the next slide for me. We are really killing it in the cultural ratings. So you can see here, I just, again, want to brag a little bit about us. Top places to work 2 years in a row, Modern Healthcare. We were just recently named the #1 hospital in the US according to Washington Monthly, which is a new, rating system. And I'll go to the next slide and show that. But before we do that, I'm going to share a little bit about what the rules of the road are at JPS. Our CEO established these. These are a core value and used through every measure of our performance rating. So they're weighted a little bit differently, but we have 3 rules at JPS. You own it, you seek joy, don't be a jerk. And that's a true story that goes a long way. And as you can imagine, we have such a dynamic CEO. There was a lot of hugging. He loves to hug. There's a lot of hugging going on at JPS prior to COVID. And so it's, we even talk to one another about, hey, when you're seeing someone, make eye contact with people, make eye contact with your team member, say hi and seek joy every day, help our patients, not just point directions, but escort our patients to where they need to go. Just really owning it, right? And so this is the core of who we are. So it's really a remarkable place. I absolutely have enjoyed my 6 years there so far. The next slide, I just wanted to point out on the next slide a quote that was made by the Washington Monthly. We were ranked #1 in civic leadership. And so I wanted to highlight a couple of things in here. And again, this is coming from them. Imagine if hospitals were motivated to rise in their ranks. They would compete to bring in patients from all levels of society, not just those that are well insured. And then just skipping on down, they would put more of their earnings into improving the conditions that affect the health of our communities. And we'll talk about that in just a minute, because it's 340B that has been instrumental in helping JPS stretch those resources to be able to do that. So on to the next slide. JPS actually has 4 subsidized programs. Basically, we're 100% subsidized for these qualifying programs. So the first one, again, JPS Connection, it's our basic program. And even in spite of that, 24% of our residents remain uninsured. But we do a lot of social events to try and advertise people come in and see if you can get qualified for our programs. The CARES program is really our homelessness program that we insure our homeless. And you can see here supplemental to Medicare. And then the final one at the bottom is we actually have a program where we're able to assist those who have Affordable Care Act plans, but still can't afford their deductibles or their copays. And we're able to do that through our JPS Foundation and able to, to kind of subsidize that and transferring one to the other. So ultimately we have 4 programs to qualify for. I believe we had our last count about 41,000 people enrolled in one of these 4 programs. The next slide talks a little bit about how do we use our 340B savings, right? So what I would call it, I called it, the benefits that we're able to underwrite because we wouldn't be able to afford otherwise. So the first one is we have 19 school-based clinics throughout our county, and they're able to provide care to not only the students there, but their siblings. We actually staff those 19 locations with an LVN, a patient access person, and a provider. And this is actually a picture of one of those locations. I mean, most of them are inside trailers, but you can see there's a sign there for that. And again, you can see that we have 35,000 encounters a year. And again, just making it so convenient for the parents of these, maybe the underserved. We do have a new oncology and infusion center. We opened it up a year and a half ago, maybe 2 years ago. We had one that was a little aged. We have a great new building, and we have about 11,000, I'm sorry, chemo and infusions a year. And you can see here our population, our patient population is over 80% Medicare, Medicaid, or one of our connection programs that serves out of that oncology clinic. And we do pretty well in the ratings on Leapfrog in that space. So it's really good. Our mobile screenings, I think a lot of hospitals do this, but of course we, again, we got to stretch that dollar to offer mammography screenings. One of the things we implemented about a year ago is having specialists, psychiatric specialists embedded in our outpatient clinic locations. And they're there to screen high-risk patients for psychiatric problems or issues. And the first year we identified 400 patients coming through on a regular outpatient visit, but we're able to leverage some of that communication by having that specialist present there that we didn't have in the past. The other thing that we offer, of course, is free pharmacy vouchers. And we had about 30,000 in a year is typical. And then they're valued about 1.3 million. And that's at 340B cost. So it's a lot more than that. And of course, we have reduced copays for our patients, of course. So the next slide. Oh, on the psychiatric program as well, I forgot to add, we have a lot of group therapies sessions that we have as well. Outpatient therapy sessions that we allow patients to come to. One of the other things that we have, which we're very, very proud of, is a mobile health van. And it's really been a game changer for the homeless. And we have and I have a quote here, he's a physician assistant, Joel Hunt. And you can see he staffs that mobile van every day. He is out in the tents underneath the bridges. He's meeting people where they are. And again, being a real game changer in bringing the vaccines, the health assessments, the lab work, some minor procedures, some prescriptions. He's able to do this every single day. And as a result of 340B savings. You can see here a quote from him. He's passionate. He's such a wonderful man, restoring hope and dignity to those who have been deprived of key principles of life. The heart for the underserved, and he likes to create innovative ways to reach them and take reality-based care directly to them. So I think, again, as you can imagine, when you take the health to the patients and the homeless, you catch early events. And so, of course, you can spend less. You ultimately spend less on their care. They're much healthier, faster, and you can, use your resources to for other things, right? Transportation subsidies. Again, considering our patient population, we have taxi vouchers and bus vouchers and gas cards. I think Ryan White actually offers the gas cards for the most part. And we most recently entered in contract with Uber Health to subsidize and to get our patients to their appointments, which has really has been, depending on the area and the county, it's just been such a struggle for us to, the no-show rate is just really unfortunate. So this has really helped us a lot. The next program I listed here is we weren't really able to get it off the ground, but it's something I think very near and dear to our CEO, his heart, and that is the food delivery program. And what we're trying to do is get healthy meals to our diabetic patients who, normally wouldn't have. What we've been doing is trying to help and partner with people, partner with restaurants and having the deliveries made. And so more to come on that one. It's still a very immature process at this point, but we'll get there. Some of the other things I didn't put on this slide were we also offer free pregnancy tests at several locations. Anytime you can drop in and get free pregnancy test on the spot. You can get confidential HIV testing as well for anybody that's above the age of 13. And I think those tests are available within 30 minutes. And then we, of course, have a 24-hour nurse advice hotline. I don't know how many others do, but that's invaluable, just invaluable, 24 hours a day. The next slide transitions a little bit because it talks a little bit, what have we done during COVID? So we were able to provide, you may have seen us, we were on the, well, if you're in the DFW area, we were on the news channel. We talked a lot about how is the North County, Texas providing COVID care at home. And that was us at JPS. So we had case managers checking on patients 3 times a day, and obviously in a lower cost setting and a much safer setting for other patients and, you know, our clinical staff to be able to provide that there. So again, freeing up some resources for that. On-demand urgent care, you know, being able to see each other face to face, that's something we had to ramp up very quickly. Weren't very mature in that process prior to COVID, but hey, we all put it together and was able to expand and optimize what we have in the telehealth space. One of the things we did as well was we knew to help isolate the spread and prevent the spread, if you will, of COVID. Early on, we opened up that convention center, of course, which was closed down for obvious reasons. And we staffed, JPS staffed that what we call the homeless in the convention center for quite a while during the initial stages of COVID. So did a whole lot. Next slide. I think it might be my last. I think it is. Drive-through COVID testing locations we set up, post-COVID follow-up clinic, COVID recovery clinic, routine drive-through checks. So you can have your A1C checked without having to get out of your vehicle in a safe environment. And then we ramped up some virtual patient education sessions, just a plethora of things we were able to do. We also did walk through screening tents outside of our ED, two separate locations for some more privacy, to be able to isolate those and to staff those. So again, we can't say enough about the savings of 340B. It's a lifesaver, and I'd be happy to entertain any questions. Thank you so much.
Thank you.
One question, Michelle. So all of these here is up under the 340B benefits.
Yeah, well, 340B benefit could cover this and more because of the volume that we have. You know, and it's really important for entities to document what are you doing with your savings. You want to make sure you're clear on how we're designating this over here and what program we've started here. And but yeah, I mean, it's exceptional. It's high.
Michelle, I would jump in here and say that's kind of the beauty of the 340B program, is that it isn't funding, it's an upfront discount. So if you go to the grocery store and you use a coupon and somebody says, what did you spend that money on? Well, I didn't spend 50 cents on milk. So I don't know, I bought other things. I used that 50 cents on other things. I think is a way to understand, you know, how this isn't a funding stream. This isn't a funding stream coming from the federal government. It's kind of more like a coupon or a Groupon. Is that fair, Michelle?
Yes, it's a savings program. Yep. All the way, yeah. And so it's the savings that enables us to put these resources in place to offer these programs.
Right.
Yeah, it's really important to identify what that looks like in your space.
Right. And it's fair to say that of all the things you've mentioned, I bet you not one of them is paid for by insurance.
You know, we have I believe altogether high 20% of insured patients.
Right.
You know, so
you're not getting anything covered by insurance because
we've got to be creative. Yeah.
Well, and two of those creative things that caught our attention were the Uber program and the COVID recovery clinic. Can you speak just a little bit more about both of those?
Now, on the recovery clinic, I wouldn't be able to speak to any great extent. I wish I had gotten a little bit more information on that. I actually spoke with our VP of Community Health, and she was just rattling off all of these things that we've been able to do subsequently. And I was trying to write fast enough to keep up with all of her advice. But so yeah, COVID recovery, again, just talking through probably, you know, I guess I'd be speculating too much if I were to go into great detail. But again, just having the resources to be able to follow through
Mhm.
to ensure we have proper care, COVID-free individuals.
Right.
What was the other one you mentioned?
Uber. So the Uber program. So you find out somebody isn't able to come to you, or they are repeatedly missing appointments.
Right.
How does it work practically?
Right. So we have as social workers and case managers involved, and typically they're routed through those folks first to qualify them. It used to be we did the yellow cab. We were keeping them in business. And it was as a result of actually one of our internal audits where we kind of dug a little bit deeper in that program and said, you know, this doesn't quite give us the information we need to reconcile where all of our money is going. So let's see if we can expand this a little bit better and have better record keeping, and then basically cut the cost of the yellow cab. So I believe we just had, it's been in the last couple of months that we've had this Uber Health contract get finalized. So I can't speak to how it's worked yet, but I know there's a lot of folks, you know, obviously Uber Health knew there was an opportunity there, and they created that, you know, subsidiary or whatever you want to call it from Uber is Uber Health. And that does in fact just give your patients rides to their clinic appointments and directly back home. No stops in between to get groceries or anything, which we couldn't tell honestly if that was ever happening in the past, but that was not the intent. It was to make sure that we kept our appointments, and has worked. I'm quite sure it's going to be a whole lot better than what we've had in the past, but absolutely. And then now that we've moved into telehealth, of course, we've been forced to do that. Hopefully we'll have some savings in that space as well, because we'll have a lot more telehealth visits instead.
Great.
Oh,
Excellent.
interesting.
So Rhiannon, where do we go next?
So this is Michelle, if you need her contact information. Thank you, Michelle. That was wonderful. Very, very interesting to me about the Uber Health, especially I personally had not heard of that, and very interesting. So that's great. And now we're going to move on to DJ. Kick it off for us.
All right, can you hear me? All right, my name is DJ Johannes. I want to say, first of all, thank you all so much for allowing us to be part of this with CV 340B and the Michelles. Just like Michelle talked about opening up a clinic in the middle of a pandemic, we did the same thing. Here is the picture of our new clinic that was opened up right in the middle of the pandemic. So it's exciting times that we live in. Okay, next. You can go to the next one, Rihanna. So we became a 340B covered entity in 2000, no, previous, back, sorry. Yeah, became a 340B covered entity in 2017. Our eligibility for 340B is based upon a 318 grant, which is valued at about $10,000 worth of in-kind support every year. The focus of our services are sexual health services through the STD clinic, and primarily focused on pre-exposure prophylaxis for HIV. We currently have 2 clinic locations, one in Fort Worth and one in Arlington, and we utilize we have 2 contract pharmacies for our 340B program. In 2019, we had 1,152 active patients for 5,542 clinical visits. 53% of our patients are uninsured, 55% ethnic minorities, and 68% are 35 years or under. Important on this is, and this is our clinic space right here, important on this is that we're focused in on PrEP services, preventing HIV. Nationally speaking, the proportion of people who are getting PrEP services under 25% are ethnic minority. We're at 55%. In addition, almost 60, I think 68%, I tried to look it up, 68% of the people who are getting new HIV infections are ethnic minority gay men. And so we really are focused in on trying to reach young gay men, get them on PrEP. For those people who aren't familiar with PrEP, pre-exposure prophylaxis for HIV, it's a daily regimen, 1 pill a day. It is 99.99% effective in preventing HIV services. And at HELP, all of our services are free of charge. There is no cost to see the provider. There is no cost for your labs. There's no cost for treatment, and there's no cost for medication, whether you have insurance or not. We're super excited about that, and we are only here because of the Kind Clinic, which some of you may know in Austin. They showed us the way. We modeled ourselves after them, and actually one of our 340B pharmacies, Walgreens, is the ones that said, you guys really have to get started on this. I was a late adopter to the whole PrEP thing, wasn't wanting to do it. As a matter of fact, back in 2017, I was looking at retiring. I was like, I've been in the HIV field for 30 years. It is time for me to go on and move on. And then what happened from us is somebody I know personally came in for HIV testing. He had asked me about PrEP services. I told him that the only place at that point in 2017 to get PrEP services was at the Tarrant County Public Health Department. They had a great program there. And he said, yeah, I'm not going to the public health clinic. I'm just not going to do it. And I said, well, you can go to Dallas. Dallas has a good program there. You can do that. 6 months later, he came back in for HIV testing. And I said, what are you doing here for testing? Aren't you on PrEP? And he said, oh, I haven't had a chance to get over there. And so, of course, as many of you can probably guess, when we tested him, this time he was positive. And this was a 50-year-old gay man who had avoided HIV infection for a long time, and just didn't go. He was really upset, said, you know, I really should have prioritized that. But quite honestly, I couldn't take off work 4 times a year in order to go to PrEP services in Dallas. So at that point, I was like, okay, we have to do something. And one of the big benefits of the 340B program is it allows you to leverage very limited resources. In Tarrant County back then, we had 1 provider for PrEP. 340B allowed us to leverage very limited resources. We opened our clinic with $40,000. We went, we figured out what it was going to take. We remodeled some space. We got our providers on board. We got our contracts. And I went to the board and said, you know, hey, if we're going to do this, we need $40,000 to make this work to get us through the first quarter. And they went out and they raised that money in 1 week. So it was a huge need. The community understood it. And we're super excited about it. The 340B program expands access to care for both insured and uninsured people. We have a number of people, PrEP services. We heard about the cost of HIV medication. PrEP services, you know, Truvada or Descovy is an expensive medication. So even people with insurance, they have a copay or a deductible. There is a deductible card that will help offset some of that cost. But there are some people with Affordable Care Act and other programs where their deductible is $10,000 a year. And the copay card's good for $7,200. So there's $2,800 difference. And through the 340B program, we are able to offset that $2,800. So even people with insurance, we're able to do it. People who are uninsured, it's not necessarily the cost of the medication because there's programs out there, but it's the cost to see the provider and to get all of your labs done. You have to have labs every quarter. We go through, we offset those costs for anybody, whether you have insurance or not. And what's really important for us is that we reduce the stigma. So we don't want people saying, well, we're going there because I can't afford it, because a lot of people may not want to admit that they can't afford it. They may not want to go into somewhere there. So by us doing that for everybody, whether you're insured or not, there is no stigma involved. Increase in community-based health promotion. One of the things Michelle talked about, advertising and recruiting. The thing with our 340B and our PrEP program is we do a broad swath of advertising and public health messaging. Without our program, that messaging would not be going out. We alone spend about $10,000 per month talking about HIV incidents, talking about the importance of getting tested, talking about PrEP, referring people to services. And that messaging is put out into the community at large. So it's not just our patients who are getting it, it's other people who are getting it as well, and they can utilize that information. It provides a safety net of services. COVID made this hit home. Right, we've always been there and opened up. With COVID, the number of people who lost their jobs and who were on PrEP and they no longer had their insurance, so they couldn't go back to their provider, for them to be able to come to us and say, I need to continue my PrEP services, and be able to do it without cost, happened immediately. People who are in serodiscordant relationships, where one person's positive, one person's negative, they were concerned about that. People who had a cut in pay because of it, and they no longer could afford their medication. And then also we've had people who've gone through divorce and lost their insurance, and being able to immediately provide for those services for those people. None of this would be possible without our 340B program. There's a couple of stories I'd like to highlight if you go to the next slide. Our college students that we work with. PrEP services, we are the help center for LGBT health and wellness. So most of the people that we are dealing with are in the LGBT community. A number of college students who are on mom and dad's insurance are not out to their mothers and fathers. And so therefore, even though they have insurance, they are not able to access that insurance without coming out to their mom and dad. So through our 340B program, we underwrite their access to PrEP services without having to use their insurance. Because you shouldn't have to choose between coming out to your mom and dad and protecting yourself against HIV. Currently, we have about 100 college students right now that are accessing our services. And it's fun, it's great for them to be in there knowing they're taking care of their health, taking care of and control of their HIV status. But it's also really interesting when, they come back in January one time and said, hey, guess what? You can start billing the insurance now because I came out to my parents at Christmas. And they're okay with it now. We also have people who are in the military. A lot of our military people use the TRICARE system, and they bill their TRICARE, and we use that for that. But we also have some people who are in the military who come to us and say, I went to my doctor in the military and told him I wanted to get on PrEP, and he told me I needed to get right with God and stop doing that stuff. And as an airman, you can't fight with the doctor. You can't force that. And so we're able to provide services for those individuals. We are the safety net services for sexual health, also looking at what the 340B is doing, just like JPS, just like Beat AIDS. What we're doing now is a community assessment saying, what are those gaps in services that are currently available? What is it that people in our community need access to that they don't easily have access to? And how can we build the capacity of our organization or partner with people who have that capacity to bring those services to our community. Mental health is a big issue, as Michelle talked about. You know, that's something that is always a need, and there's always availability issues. COVID, it was amazing. You know, I'm the CEO of the Help Center, and we had talked about doing telehealth, as did almost all the other organizations that we dealt with. And prior to COVID, we're like, well, but you know, you have to look at HIPAA and it's going to be so complicated, and you know, but we have to do this and we have to do that, and it's just going to be so hard. Yeah, we're going to do it. Let's study it. Let's do this. Let's do that. COVID hit, and it's amazing what you can accomplish in a very short amount of time when you have to do it. And quite honestly, without 340B funding and 340B savings, we would not have had the capacity to get through those hoops as fast as we have done. We opened up our telehealth or our teleprep program, and now serving a lot of people through the teleprep program, not only here locally, but also through the state of Texas. Some takeaways next. Our 340B program leverages $10,000 worth of in-kind support services, and last year we delivered $17 million in care. Our patients did not pay 1 penny for that care. Our program alone prevented 46 new HIV infections last year. CDC estimates for every 25 people you have on PrEP services, you avoid 1 HIV infection. So that's saving a lifetime cost of $15 million per year. Every year we're saving that money. Our administrative costs are less than 5%. The 340B serves a critical need in every single community. It has been witnessed today, whether it's about sexual health for the LGBT community and the needs there, whether it's on a community-wide basis like JPS and all of the wonderful services that they do. It's amazing the amount of support that 340B gives JPS, and you look at JPS Hospital with 22% of the people being insured and they're the #1 hospital in the nation. That doesn't happen without 340B. That's not possible. You can't tax enough money to make that happen. You can't fund money through the Commissioner's Court to make that happen. It is the 340B savings which offers that. And Beat AIDS, awesome program, expanding services to the African American community, making sure that those needs are being met. There's not enough money to fund and to raise and to beg, borrow, and steal to provide the services that these organizations do and that we're able to do. And the most amazing part is it costs our federal government not 1 penny. This is a community-based response. It's our community taking care of community, and it's super important that we protect it and we get on and advocate with our elected officials and community leaders, because if 340B goes away, it will be absolutely detrimental across the board, not only to the gay community, not only to the African American community, but to our entire county. And every single county in the nation will have an impact because we have built all of these programs that serve critical needs based upon the 340B savings that we're able to do. And Big Pharma is making big money. They're not going broke through 340B. Love them, and we work really well with them. But you know what? We know how to fight when we need to. And sometimes you just have to do that. And so it is a partnership between community-based organizations, Big Pharma, with the pharmacies, and all of our community partners that make all of these things happen. I appreciate very much the opportunity to talk with you all today. We're super excited about the things that are coming on. We can't wait to show off our new building once we're allowed to get together in groups of more than 5 or 10 people. But it has given me much more time to be able to fine tune stuff without having to jump through the hoops wondering who's going to walk through the door.
Right.
I'd be happy to answer any questions that anybody may have.
Thank you, DJ. That was a fantastic job, and you kind of summarized it beautifully. We have kind of almost run out of time, and there is one more section that we want to get into, which is really important. We hope that we've convinced you today that this is an important program that you all need to protect. And there are little things you can all do to help us protect this program. So I'm going to turn it over to Rhiannon now to talk about what some of those things are you could do. And we promise to follow up with you as well. Those of you who are interested in lending a hand, it may be as simple as writing an email to your member of Congress or your local legislator. Something as simple like that, but we really do need your help because a lot of folks would like to have the savings that we get. And we think how we're using the savings in Texas in particular is pretty amazing, and nothing should prevent that from happening or being as wonderful as it was just described to you today.
Absolutely. I'm going to go through this in the next 5 minutes. As Peggy said, what we'll do is we'll follow up for a separate brainstorm session. If you're interested in advocacy around the 340B program and you're interested in getting involved, we'll have a separate session where we can do some peer-to-peer advocacy input, generate some ideas, and move forward with our grassroots advocacy for CV 340B in Texas. Some of the ways that we do grassroots advocacy in Texas are to educate our advocates about what 340B is. So everything that you've heard today, we kind of sum them up in little infographics like the one that you're seeing right there. We also do several other very impactful advocacy tools within CV 340B, writing a letter to the editor, signing a petition, which is on our website, hosting an event, telling a story, being on social media and sharing our story on social media, leading a Community Voices team, or telling a friend. Some of the ones that I'd like to highlight here are sign the petition. We have a petition on cv340b.org. You can go there right now and find it. It is under the Get Involved tab, and you can sign the petition and say, hey, policymaker, this is what we think is important in our community. We think 340B is important. Please protect it. A couple of other things I'd like to highlight. Being a social media ambassador is the heightened of advocacy right now because of COVID-19. We can't necessarily get together. That's, unless you're going to be outside and you're all going to be, in 4 corners of your backyard, we can't really get together. So go ahead and give us a like on Facebook, Twitter, and LinkedIn. We are CV340B. And you can find us that way. If you are in contact with myself through email or John Reed, we can point you there and I'll send all of those things to you via email. Some other things that we do on our website, we have a sample letter to the editor and a sample email to members of Congress. These are both very effective tools for advocacy. We also have infographics that you can share. You can customize and share on your social media. Again, that social media is super important. During our next session, because now we're going to have a next session on our face-to-face advocacy via Zoom, we'll talk a little bit more about the unique ways that your community can get involved. Some of the ideas that we've had in previous sessions are civic organizations like the Kiwanis or the Lions Club. Do they need to hear about this? maybe some sorority fraternity that you might have, Greek life that you're connected with. Those are great places to talk about 340B, things like that. So we're very, very excited to get this kicked off in Texas. John Reed is available to all of our Texans. I will share with you his information via email. I will also share Peggy Ty's information and the rest of our panelists. And we'll go ahead and schedule a alternate Texas Opinion Leader advocacy session that we can do some real peer-to-peer talking.
Rhiannon,
If you,
Rhiannon, if I could just jump in really quickly.
Yep.
One of the chat messages reminded me that there are not just 3 340B covered entities in Texas. There are hundreds of them. So
yes.
look around, find out, ask when you're visiting a hospital or a clinic if they work with the 340B program, if they are 340B eligible. Learn more. You can learn more about the program by asking your local providers. Again, it wouldn't be an individual physician, but a hospital or clinic. It would be nice to know and to start the buzz that way as well.
Absolutely. The last thing that I wanted to say, and then I'll let you close it out, John, is that we are available throughout the state of Texas. So if you have questions, if you're wondering if, like Peggy just said, there's a 340B covered entity near you, things like that, please reach out. Please reach out to myself, reach out to John. We're happy to get you any information that you might need.
Hey, Rhiannon, can I jump in real quick?
Yeah,
2
go ahead.
seconds? The other thing, as we all know, coming up in, I don't know, 73 days is an election. And if you happen to be in a room with somebody who may be running for state or federal office, just asking them, you can say, hey, the 340B program is really important to me. What are your thoughts on it? You know, you want to be really careful about advocacy versus lobbying, but you know, it's really important to me in our community. What are your thoughts on it? Chances are they're not going to know anything about it, but you're going to bring it up and they're going to remember that they didn't know about it and they're going to look into it, and you want to talk to them, open the door to talk to them about it.
Yeah. And
Absolutely.
all you have to say is it's all you remember is 340B drug discount program. That's it.
Absolutely.
Great suggestion, DJ. Ask any elected officials, any local or state or federal elected officials, do you know about this program? It matters to me. That's all we need.
Yep. Yep. Absolutely. All right, John, would you like to end us up?
Yes, I just want to again apologize for the mix-up when we got started. I didn't get a chance to introduce my friend Michelle, but the next time I'll be able to introduce you. And again, you know, I know a lot of more folks were supposed to been getting on, and we have to keep in mind that we are in the middle of a hurricane. So I know a lot of folks in Beaumont, Houston, other places weren't able to get on, but the ones who were on here today, I want to thank you. I want to thank you from the bottom of my heart. And like you said, Michelle, we're going to do another one before the year is out. I hope so. I hope we're able to do that. And I want to thank all the participants who was on here today. There's one in particular participant I just want to highlight, because before the COVID-19, they was going into senior citizens' homes, and they was doing workshops on 340B program, educating senior citizens. And I just want to thank her for doing that. And I want to thank everybody who had been able to help me promote the 340B program throughout the year. And I know when COVID is over, we're going to get back out on the trail and educate some more. Thank you, Peggy. Thank you, Rhiannon, for entrusting me to be a part of this great team.
Thank you. And thank you
Thank
to
you.
our frontline healthcare providers that you either are or you work with, our panelists. Cheers, applause, and it's great to hear your stories. Thank you for sharing. Rhiannon,
Yes.
any parting words?
And one more thing,
This,
DJ used to be my boss and a great boss, and I look forward to seeing how you're gonna grow in Texas, DJ. Good work you're doing here. And Michelle, I'm gonna get a chance to get over there to JPS and get a chance to meet you.
this webinar has been recorded, so it'll be up on social media and our website within the next few weeks. So keep an eye out for that as well. Other than that, thanks everybody.
Shout out to Deborah Carr. I got to do that. A shout out to Deborah Carr up there in Austin.
Awesome. All right, everybody, we'll let you go. We won't take any more of your time. Thanks so much for joining, and we will see you on an advocacy session soon.
Thanks, everyone.
Thank you, Community Voices. Thank you so much.
Thank you.
Bye.